Welcome to Digital Health Talks, where innovators and changemakers share how they're transforming healthcare through technology. Join Megan Antonelli, who will be shining a light on the good things happening in digital health.
Hi, and welcome to Digital Health Talks. This is Megan Antonelli, CEO of Health Impact Live. Everybody is talking about AI, but the real question is whether it is actually expanding access, improving care, and changing how healthcare gets delivered, or just optimizing what already exists. In California's Central Valley, one pediatric health system is not waiting for the answer. Valley Children's Healthcare is already operating AI across 3 distinct layers of care delivery, and their outcomes metrics are beating industry benchmarks. Today, I'm talking with the CIO who is building the stack from the inside. Joe Egan has spent more than 25 years at Valley Children's, rising from network technician to vice president and chief information officer. He led the first fully remote Epic implementation in the country. He holds a master's in information security, and right now he is one of the most important voices in pediatric digital health. Joe, welcome to Digital Health Talks. Nice to see you. I'm so glad you could be on the show. How have you been?
Megan, pleasure to be here. Thank you. I've been fine. Everything in California is going well.
I know. Well, the summer's off to a start, so it's a little hot where you are, a little hazy where I am, but we're not too far away. You have been at Valley Children's there in Madera, California for over 25 years. And tell us a little bit about, your journey, how you started there and now as CIO, what that looks like.
Sure. Yeah. So Valley Children's has basically been my home for most of my professional career. And starting as a network technician really taught me that technology adoption happens from the ground up too. And I started as a temp for Valley Children's Hospital back in 1996 or 7. It gets hard to remember when you're talking about that many years. Started as a temp and then went into networking technology. I had the pleasure of helping to design the first network for Valley Children's when we built the new hospital, which opened in 1998. And so know where every little nook and cranny is in Valley Children's Hospital. I did leave for another organization in 2008, but came back in less than a year. But Valley Children's has been home for most of my career.
Yeah. Well, I think, what a great story. And I love that you started as a temp. I actually, one of my first jobs in healthcare was as a temp at Kaiser up in Oakland, and then went on to work in contracts there for a little bit. So, amazing how we get to our starts. And I remember temp jobs well. I feel like we don't have them as much anymore, right? Now they all intern and then get jobs, right? But back in the days in the late 90s. But tell our audience a little bit about Central Valley. Set the stage in terms of Madera County, what that looks like for those who might not know where it is there in the Central Valley of California.
Sure. Yeah. So for Valley Children's, Madera County is our home, but our care environment is really the entire Central Valley of California. We have more than 1.3 million children across roughly 46,000 square miles. And that includes many rural and historically underserved communities. In our environment, families may have to travel for hours historically for pediatric specialty care. And so we prioritize technologies that help move our expertise closer to the kids and make it so it's easier to get to that care. Our CEO had a goal of care for children within 20 miles or 20 minutes. And so we've worked hard to build that by reaching out to partners and partnering with other healthcare organizations by having NICUs that are Valley Children's NICUs in third-party hospitals, specialty clinics that are closer to homes. And so that's been a huge part of our efforts when it comes to technology too, is how can we bring access closer to the patient?
Yeah. And I think it can't be kind of understated how and where you are. I mean, you're about 4 hours from LA and probably maybe 3 hours from San Francisco, right? So it's a far, kind of right there in the middle, hence the Central Valley. But, in terms of what's there, and that you have Fresno, but that's and it's a city, but in terms of access, California gets pretty rural pretty fast as you get out of those major metros.
It does, especially in Central California too. And where you might have a metropolitan area that has 1.3 million patients for an organization within a single zip code. We have, like I said, 45,000 square miles. And so access is tricky for patients. And so that is one of our key focuses.
Yeah, absolutely. And then, in terms of the physician and physician demographics and kind of keeping that, and then, sort of pediatrics. Even just here in LA, it's hard to get pediatrics appointments when you need them. And then the ability to travel, we talk about it a lot on the show, just about, when you have sick kids that you don't want to travel with them, certainly not miles upon miles, and often you don't have to. So that kind of access that technology can bring is very important. So tell us a little bit about kind of what brought you to where you guys are now in terms of looking at these tools, both for, efficiency, but also for access.
One thing that I've stressed to my team is the tools matter, but the trust in the tools, the workflows, and the training, and even leadership ownership matter more. And so when clinicians and operational teams help us define the problem and they take ownership of the outcome, that's when, in my opinion, technology sticks. And so if IT simply installs a new tool or installs something, it usually doesn't. And so I've found when it comes to these tools for access or whatever the tool is meant to help us with, people rarely resist the technology just because it's new. They resist it when they think it's going to make their work harder, or if they don't understand why this tool is being implemented or why we're changing something, or if they don't feel heard. And so you had mentioned tools. That's one of the major pushes that we have, is to make sure that there's operational ownership in all of these different tools. The tool is just a tool. And so it's really the workflow that the operational teams need to take ownership of and treat IT and information technology services as a partner to improve those operational workflows. And so, for example, when it comes to access for Valley Children's Hospital, telemedicine and remote access is a huge push that we've made in the last few years, especially since COVID. And we continue to this day. Having 45,000 square miles, telemedicine is important for Valley Children's Hospital, both giving specialty care to other providers, so we can have telemedicine providers helping other clinicians in other hospitals or clinics, or meeting with the patients directly. And so we've spent a lot of time and effort on those types of tools for telemedicine, both directly with the patient in mind, but also with other providers in mind.
Yeah, I think the impact of the pandemic on sort of that need and also acceptance for telemedicine, particularly, across pediatrics, is so, has been such an added benefit, a silver lining, if you will, to that and that adoption side of it, particularly in rural areas. But as I said, here in, cities, urban areas too, it makes a huge difference. Around, with the AI implementation, your background is very much a technologist in IT. And I think there's, you mentioned kind of that it's the technology is there and it becomes around the sort of the governance and the workflows and kind of getting the ownership and how important that is. But let's talk a little bit about the technology. I think, when we talked a little bit that you're operating the AI at kind of 3 levels. Walk us through the architecture a little bit. Where does, how does it start and how do the layers build on each other?
Yeah, so I would not claim that Valley Children's is at the bleeding edge of artificial intelligence. We try to remain cutting edge, though, as close as we can. But we do see AI from 3 distinct levels. First would be to assist our clinicians, the second's to inform, and then the third is to act. So, for example, assist a bridge. So we've recently installed a bridge, which is our ambient documentation technology, to help providers document easier and be more detailed in that documentation too. There's also Epic AI features that we've implemented, inbox assistance and coding and administrative automation technologies. These, in my opinion, are there to assist our providers and workforce members to do the work that they normally do. Then there's the inform layer. So how can you use things like Slicer Dicer, Epic Cosmos, or Microsoft Fabric, which is now one of the tools that we're implementing for data and data analytics, Power BI. How can we integrate artificial intelligence and other technologies, data science technologies, to help better inform the providers so they can make better decisions and help them with their process? And then how can we act? And so this is the squishy part for us, and we're not here yet, but the future is agentic workflows. And how could we use that to coordinate appointments and conduct outreaches and close care gaps and support our clinicians and operational teams with clearly defined human oversight, which is important. Many organizations are starting to get there. There's just so much complexity to that. And you had mentioned governance, and that's the first thing that we did was put in a pretty robust artificial intelligence governance process and committee, so we can make sure that we don't get ahead of our skis when it comes to the ACT perspective.
Yeah, I think that's great. I love that in terms of the way you've broken that out into those three levels. So it just so I remember, it is inform, right? Assist, inform,
and act. Yeah, and we look at it from how much risk is there for each one of these levels too. So assist, that's the lowest risk because you have the most supervision over artificial intelligence. It may be doing the work for you, but you're making sure that it did it correctly. Ambient technology, the providers use it to automatically create that documentation, but then they're reading it and making sure it says what they want. So it's completely supervised. Inform's a little bit different. Now you're trusting artificial intelligence a little bit more to give you recommendations. It's still clinicians making decisions and workforce members. But when you get into agentics, that's where it becomes a little bit squishier because you're giving it less supervision and more autonomy. Mm-hmm. And so, and again, I don't pretend that we are there when it comes to that level. We are now just dipping our toe into that pool and starting to watch other organizations and what are they doing and how can we be as cutting edge as possible without being bleeding edge.
Right. No, absolutely. The trade-offs to the ACT are tough. And I mean, I find it even in my, kind of low risk, more marketing, world of it, as you kind of hand over more, there's almost more work to do because you've got to double check and get more involved in that. Let's talk a little bit more about the ambient deployment, in that was the earliest. And I think that assist people lots, we hear the statistics. There's no question everywhere. It says, don't take it away from my docs. This stuff is working.
You're listening to Digital Health Talks. When we return, we'll continue our discussion on how technology is revolutionizing healthcare delivery. Stay with us to hear more insights on creating sustainable, patient-centered digital health solutions.
With any new tool that we implement, there's one signal that I always look for. Do you have to push that tool or is that tool being pulled? And so for what I mean by that is there's oftentimes when you just have to push out a new tool for various reasons. There could be your old technology is now end of life and you have to move to a new technology as an example. And so you're pushing that out and you might have some resistance from the organization for that technology. But if your organization is pulling it, if they want that technology and they're asking for it, that's a huge signal of success. And so with ambient, there was a great pull signal where after our pilot, we had other clinicians that were asking for it. Matter of fact, we have a wait list right now for clinicians who still want it, even after our go live and production rollout. And we're just waiting to see if we can add more physicians here in the future. But the the fact that physicians are asking for it is a great signal. There's also metrics that we look at too. So one thing that's called pajama time, and that's how many physicians are working after hours, either working from home, trying to document. That is for the physicians that have these tools noticeably lower, and so going down, which is great. There's time in notes too. So how much time a physician spends in the note documenting for our ambient providers is much lower than physicians that are not using it. And so that's a great metric too. That could translate directly into access. And so looking at physician acceptance for ambient technology is great. But if we can move that into, does this provide better access for our kids? That's the metric that we really want to use. And so we don't have direct linkage to that metric yet to say, yes, we can see more patients, because it's very complex. There's other reasons that you may not see more patients than just ambient technology making it easier to document. But it certainly is not hurting. And so this is one barrier that we can remove now to provide more access to kids. And that's one of the most important things.
What about, in terms of that documentation and the billing and the, sort of coding pieces of that as it goes upstream, are you seeing any metrics around, sort of coding and revenue recovery and that sort of thing? Or is this primarily around the physician and kind of the assist part of it?
It's primarily around the assist, but there is anecdote, and this is too early to tell yet, but one thing we are hopeful of is that the ambient technology is going to make it easier for RevCycle to close the loop. For example, one thing that happens is if you put in codes and now this goes to your payer to say, these are the charges for this particular encounter, payers are looking for the documentation as evidence that, yes, those are things that happen. And in the past, if a physician did not provide that evidence in the note, then you could have denials, more denials. And so then you have to go back and then look at that and then provide that evidence back to the payer. And anecdotally, what we're seeing is better documentation in the note that justifies those charges. And so less denials. That's the hope, is we're going to be able to actually watch this and watch denials, first-time denials go down, because ambient technology is providing better evidence in the document, in the notes.
Right. And then I have this hope that eventually the data's there, the denials happen, then they all, the appeals happen, the process happens, and it happens so much that it becomes reductive, and then it stops happening altogether, right? That's my vision for all of this, is that the battle of the bots happens, and then in the end we realize, well, that was all silly, and we should just stop doing that and give people the care that they want when they need it.
Exactly. Yeah.
Right. That's the vision. That's the hope. And it will require those three levels of AI to be working together across both clinical and the financial systems. But things are moving so fast. I think we're getting there faster. So when you talked a little bit about the other tools in terms of that inform piece, the data analytics, the Epic, Microsoft Fabric, tell us a little bit about that in terms of, the population level data and kind of what you're seeing there, and any gems that have come out of that usage.
Sure. I don't want to overstate our current maturity when it comes to those types of tools. We do, for example, have Epic Cosmos as one of the tools that we have in place. And the goal for those types of tools is, let's say you have a rare pediatric disease. A children's hospital often does not have enough cases to create that reliable evidence to say this is the treatment that's standard for this type of rare disease. And Cosmos gives clinicians access to a much larger de-identified population so they can find those similar patients and patterns. This is something that's new to Valley Children's that we just implemented recently, but that's the goal, is to provide that type of evidence to our patients so they can it can help them in that rare pediatric disease process. And so Cosmos is one of those tools. We do have other reporting tools that we have here in Valley Children's data landscape, such as Slicer Dicer. I'd mentioned Microsoft Fabric. That is a current implementation. So we are moving away from our old data warehousing technologies to Microsoft Fabric and connecting our separate and disparate data systems into Microsoft Fabric, because this will allow us to have even additional tools to be able to do some of these things, like APIs for artificial intelligence that we can use, natively from Microsoft Fabric, data science tools that we did not have in the past that we can start using here in the future. It's new, it's a breaking path for us, but we're excited about that direction so we can give a higher level of data tools and resources to not only physicians, but to all of our workforce members.
Yeah, I love that. I mean, I think that the rare disease piece, there's so much, and we talk about this a lot in terms of, AI being able to enable some things that the resources weren't there to do before. And again, when you think of the data and the pool and the access to it and the ability to do the analysis without necessarily investing millions and millions in the research to do it, that identification. I mean, we talked a little bit about Judy Faulkner's recent interview, and she talks about how much patient data is actually in, the Epic system. Now we all know some problems with the connectivity and what you can truly access and all of that kind of stuff. But at the end of the day, the promise is there, the potential is there. And I think for pediatrics in particular, where one, clinical trials are tough, and two, the data pool is smaller, that doing that kind of research is hard. So tell us a little bit about, kind of your experience specific to pediatrics, with AI development and kind of what you're working on, and how you're solving for that.
It's an interesting question, because when it comes to pediatrics, AI or other technologies, a child's not simply a smaller adult, right? An adult trained AI model cannot be assumed to work safely in pediatrics, just like other things, like imaging, for example. You might have imaging systems that have artificial intelligence and other technologies to be able to help a radiologist spot things. And those things are typically tuned for adults. And so it's always been a struggle in pediatrics to get these tools to be at the cutting edge. I know I keep saying cutting edge, but it's always been a struggle. And so we're hoping that these types of technologies will help us address that problem through collaboration and shared de-identified data sets and pediatric specific validation and ongoing monitoring, lots of different ways that this will help us specifically at Valley Children's in the future.
Yeah. I do think that pediatric health systems are some of the more collaborative health systems in the country because of that, right? They kind of often stand alone in their market, and then they can collaborate across the markets very well. So that's, standing on the shoulders of others and letting a few, bleeding edge versus cutting edge. It's all, it's good to be striving for the edge and trying to kind of push it forward. And it's clear you guys are doing that really well. I mean, you talked a little bit about, kind of the culture and the work, and I think that's something we hear often is, the technology is there, the work is in kind of the implementation and bringing the change. And while ambient has been one of those things that, the speed to adoption and the desire to adopt is there, it's not always, and getting that culture to build. And I think when we think about where the EHR came in and perhaps was not a pull, or it was a tech we had to push, right? from the very levels of the top layers of the government to push it, right? That there's this, it's changing now, but that doesn't mean the organization is there to kind of support all of that. So talk a little bit about what you guys have done around that to build the culture, and to make sure things, if something breaks, if something doesn't go, that gets fixed too.
Sure. So I'll go back to something I think I said, which is IT shouldn't own the process, especially the technology discipline. IT should own the security and architecture and integration, the reliability, be part of the governance. But I believe that operational leaders need to own that workflow and adoption and outcome for that to be really integrated and accepted into the organization. And that's something that we have really built into our governance processes here at Valley Children's. We have 4 main technology governance groups: information security, technology and business systems, EMR and clinical systems, and then data governance. And so all of those are very, very important. But most importantly is the membership in those governance groups are outside of IT. They're outside of technology. And we strive on making sure that those members understand that they own these technologies and these workflows and have to make decisions. I don't know if this is a good example, but I always say IT is like the mechanic and you own the car. We're not going to tell you where to drive it, but we're definitely going to tell you you shouldn't drive 100 miles an hour on a dirt road and you shouldn't take your car there. And we need to be partners, but IT shouldn't be telling you what to do with this technology and when to use it. That needs to be a partnership. And so very important, we do own project management. We do own implementations, but when it comes to care transformation and innovation, that is definitely a partnership. I'll give you one example that we're going through right now. It's a small example, but it's our intranet. So we have an intranet that we call George Page. And so George is our mascot for Valley Children's Hospital. It's a giraffe. And the reason is, I don't know if you know this or not, but giraffes are the largest mammal that have the largest hearts from any mammal perspective. And so that's a perfect example of our mascot because we want to have the largest hearts for our kids. And so George the Giraffe is our mascot. And so our intranet page is called the George Page. And we are going through a pretty significant upgrade and moving the George Page to cloud services, and Microsoft SharePoint 365 will be that platform. And part of that project was bringing the workforce members and organizational leaders outside of IT into this, saying, look, you need to tell us how we're going to do this and how it's going to work properly and how you want to use this, because it is not an IT system. We even implemented a governance system on change management during this process, during this project, to make sure that organizational leaders are going to, in the future, after implementation, make decisions on changes to the intranet page too. It's a small thing, but it's something that we try to do for any technology for the organization.
Yeah, I love that. And great talking to you. Thank you so much. Really enjoyed it. And I hope to see you soon at an upcoming show. To our audience, if this conversation got you thinking, that is the whole point. Share it with someone who needs to hear it. Subscribe to Digital Health Talks. Follow us on YouTube at Health Impact Live and visit healthimpactlive.com. I'm Megan Antonelli, CEO of Health Impact Live, and this is Digital Health Talks. Let's keep fixing healthcare one conversation at a time.
Thank you for joining us on Digital Health Talks with hosts Megan Antonelli, Janae Sharp, and Shahid Shah. For more insights on healthcare innovation and a deeper dive into today's discussion, visit healthimpactlive.com. Join us next week as we continue exploring the technologies and strategies transforming healthcare.